Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotations and you are more confident in caring for the critically ill patients. Death is medically confirmed with a simple physical exam showing complete unresponsiveness to all stimuli, fixed and non-reactive pupils, absence of any respiratory motion, and most importantly, absence of pulse and heart sounds. Ultimately, all of these are functions of two vital organs. First, the brain, which controls consciousness, pupillary reflexes, and respiratory drive, and the heart, which is responsible for circulation. The heart and brain share a special relation. Complete loss of function of one of these organs invariably leads to loss of function of the other organ. For example, if the heart stops pumping blood, it leads to circulatory arrest, and every organ in the body suffers from lack of continuous supply of essential nutrients like oxygen, a condition called ischemia. Brain cells are especially sensitive to ischemia, and if blood flow is not restored in time, brain cells can die within minutes. Some common conditions that can cause cardiac arrest can be remembered with the clue 4H and 4T. These conditions are shown in the table. Complete loss of brain function can ultimately lead to death of cardiac muscle as well. Here is how it happens. The lower part of the brain called brainstem controls the respiratory drive. When there is death of the entire brain tissue including the brainstem, the patient loses ability to breathe, a condition called apnea. And when the breathing completely stops, the blood levels of oxygen drop, a serious condition known as hypoxia. Hypoxia leads to electrical and mechanical instability of the heart and ultimately cardiac arrest. Such serious injury to the brain is called catastrophic brain injury. It can be either primary, common examples are intracranial bleeding, massive ischemic stroke, obstructive hydrocephalus, or secondary, which means the insult originally starts in a different organ. Most common example is cardiac arrest, which leads to global anoxic brain injury. All the injuries we talked about in the last slide can cause global cerebral ischemia by raising the intracranial pressure. Let's understand how that happens. Cerebral perfusion pressure, which determines blood flow to the brain, is the difference between mean arterial pressure and intracranial pressure. When there is catastrophic brain injury, let's say in the form of severe intracranial bleeding, it leads to elevated intracranial pressure. And when the ICP is elevated enough, that can lead to severely compromised cerebral perfusion pressure. In extreme cases, when ICP becomes equal to MAP, the cerebral perfusion pressure becomes zero, and that can lead to complete death of the brain cells. The brainstem is relatively resistant to ischemia, and when there is compromised cerebral perfusion pressure, the death of brain cells progresses from the top, the cerebral hemispheres, towards the bottom, the brainstem. Within the brainstem, the distal part is called medulla oblongata, which controls the respiratory drive. So when there is apnea, it indicates complete evolution of death of the brain tissue. Again, when there is complete loss of brain function, it ultimately leads to loss of cardiac function and vice versa. Regardless of where the injury starts, the complete loss of function of both the brain and the heart means the death of the individual. This is again medically confirmed by an exam showing complete unresponsiveness, fixed pupils, loss of respiration, loss of pulse, and absence of heart sounds. Medical confirmation of death based on this approach is called cardiopulmonary death or sometimes cardiac death. This is how death was medically confirmed. In fact, until the mid to late 1900s, this was the only method of medical confirmation of death. However, something changed in the mid to late 1900s that led to the only other method of medical confirmation of death, which is the brain death. In order to understand brain death, we need to understand the timeline of events that led to its inception. In 1940s, mechanical ventilation was invented. This has revolutionized the care for critically ill patients where the machine can deliver breaths directly into the patient's lungs through a breathing tube, despite the patient's lack of ability to do their own breathing. In other words, patients who are being mechanically ventilated do not develop apnea. Since mechanical ventilation blocks apnea from developing, patients who develop complete loss of brain function while on mechanical ventilation will not progress to hypoxia and ultimately will not have cardiac dysfunction. In 1959, two French neurologists published a case series where they described certain patients on mechanical ventilation who were completely unresponsive without any brainstem function, including loss of brainstem reflexes, loss of respiratory drive, and flat line on electroencephalogram. All of these would indicate complete loss of brain function. They called this state as le coma dépassé, which literally translates into a state beyond coma. Such patients are technically dead, except that the natural process of death was being interrupted by mechanical ventilation. Therefore, the traditional criteria of cardiopulmonary death could not be applied to these patients. So this led to a lot of moral burden on healthcare providers as they're caring for patients who are dead, and that is neither meaningful nor respectful to the patients. In 1981, in the US, the President's Commission on Bioethics was formed to bring the experts together and address this issue. The next year, the Uniform Determination of Death Act was passed. This included brain death, now also known as death by neurologic criteria, as an acceptable and legal method of confirmation of death. They defined brain death as irreversible cessation of all brain functions, including the brainstem. And this is how brain death came into existence. The guidelines for brain death testing come from the American Association of Neurology. In 2023, several societies, including the American Association of Neurology, the American Association of Pediatrics, Child Neurologic Society, and Society of Critical Care Medicine, came together and updated the guidelines. This was a big deal because it was the first time all these societies came together, and also the guidelines were updated after several years. You can access the document by scanning the QR code on the screen with your phone camera or by clicking the link provided in the description. This article forms the basis for the rest of my talk, but keep in mind that I will only be talking about brain death in adults. Different rules apply for brain death in children, anyone under 18 years of age, and I will not be covering that. Now let's discuss the actual process of brain death testing. There are 4 steps involved. First is the prerequisites, second is a thorough neurologic exam, third is apnea test, and fourth is ancillary testing, which is basically a specialized form of brain imaging, but that is not necessary for all cases. Keep in mind that this sequence must not be broken. You have to start with prerequisites and then proceed to step 2 and 3. You cannot do apnea testing first and then go back to do a neurologic exam, and never get ancillary testing without doing a thorough clinical evaluation first. There are 3 prerequisites that must be met before any further testing for brain death can be done. These are coma, cause, and confounders. Let's talk about each of these. Coma is absence of any motor activity originating from the brain. This means patient should be unresponsive to any form of stimulation, especially including painful stimulus. There should also be lack of any obvious brainstem activity. For example, if you walk into the patient's room and they are breathing on their own or they are coughing, these are brainstem responses and you wouldn't proceed with brain death testing in such patients. The second prerequisite is the cause. It is a must to identify the cause of catastrophic brain injury. We already covered some of these causes in a previous slide. It is also important to establish permanence. For example, if you have a patient who is presenting with catastrophic brain injury, the first step is not to proceed with brain death testing. The first step is to stabilize the patient, put the patient on ventilator if needed, and provide appropriate treatments like stabilizing the blood pressure, consulting neurosurgery, and so on. While a waiting period is recommended to establish permanence for all these conditions, guidelines do not provide strict recommendations on the time, except for global anoxic injury in setting of cardiac arrest, where at least 24 hours of waiting period is recommended before you do any brain death evaluation. The final prerequisite is that confounders must be eliminated. There are several conditions that can suppress the central nervous system and mimic findings of brain death even in the absence of direct injury to the brain cells. Let's talk about each of these. Drugs including prescription medications and alcohol can suppress the central nervous system. You want to make sure that the effect of drug is gone before you do any brain death testing. Consider this example. You have a patient with ruptured aortic aneurysm who had a long surgery, had massive stroke as a complication, and you just received this patient to your ICU from the OR. Would you proceed with brain death testing on this patient? No, because the patient had a prolonged surgery, received sedation, most likely even paralysis. You want to make sure that you wait for at least 5 half-lives to pass before you do brain death testing. If the patient received paralysis, you want to make sure the effect is gone based on your physical exam or train of 4 testing before proceeding with brain death evaluation. There are several endocrine and metabolic derangements that can interfere with neurologic testing, and depending on the patient, you want to check for these abnormalities and correct them. However, there are no strict cutoffs. For example, if the patient's sodium level is 133 and that's around patient's baseline, you can probably proceed with brain death testing, but don't do it if the sodium level is 102. The American Association of Neurology article has some suggestions for cutoffs for several of these conditions, and you can access that by scanning this barcode on the screen or by clicking on the link provided in the description. Hypothermia, especially severe hypothermia, is a mimicker of brain death, and any patient whose core body temperature is less than 36 should not have brain death testing done. Hypothermic patients should first be rewarmed, and at least 24 hours should be given after the temperature is persistently above 36 Celsius before doing brain death. This also applies to patients who undergo targeted temperature management following cardiac arrest. So let's say, for example, patient had a targeted temperature management with a temperature of 34 Celsius. You want to gradually rewarm the patient after completion of the treatment, and once the body temperature reaches above 36, give additional 24 hours before doing brain death testing. Hemodynamic instability also causes CNS suppression, and it is important to maintain adequate blood pressure before doing brain death testing. A thorough clinical exam assessing the brain function and brainstem reflexes is the most important aspect of brain death testing. Brain imaging is only ancillary, and it is not required in all cases, and it does not replace clinical exam. I will demonstrate clinical exam using this mannequin. Start by calling out the patient's name. If no response, move the patient by grabbing the shoulder. Do a deep sternal rub. Noxious stimulation should be provided by applying deep pressure on the nail bed using a hard object like knee hammer or a pen. It is important to provide such noxious stimulation at different sites on the extremities and trunk and assess for any response from the patient. Keep in mind that when there is severe peripheral neuropathy or cervical cord lesions, we may not see a response to such stimulation. Therefore, it is important to assess for response to noxious stimulation at proximal sites as well. Apply deep pressure at supraorbital notch. Apply deep pressure at temporomandibular joint. To assess response to visual threat, pull the eyelids open and perform a maneuver as shown. Be careful not to directly touch the eyeballs. For oculocephalic reflex, the eyelids must be pulled open and the head must be tilted from side to side as shown. In a brain dead patient, the eyeballs must be fixed and they should move with the head. There should not be any movement of the eyeballs independent of the head movement. If a patient has cervical spine injury and is placed on a C-collar, you will not be able to perform this test. In that case, you can actually skip this test. This is the only test that can be skipped in the entire neurological exam, provided you can do the oculovestibular reflex testing, as will be shown later. Provide noxious stimulation to the nasal mucosa using a cotton swab. This is similar to doing a COVID test. During any noxious stimulation, assess for patient's response, like facial grimacing, becoming uncomfortable and moving away from the pain. Such responses indicate intact brain function and patient is not brain dead. You don't have to proceed to the next step of the testing. Check for gag reflex using a hard object like a plastic suction catheter. Insert it into the mouth beside the ET tube and apply some pressure in the oropharynx. Endotracheal tubes have something called inline suction catheter that is covered in plastic sheath as shown here. You can check for cough reflex by advancing this catheter all the way in through the tubing into the patient's airways. Once it's advanced all the way in, apply suction and start pulling it out. A brain-dead patient will not have any cough reflex to this maneuver. To check for oculovestibular reflex, first make sure the head end of the bed is elevated to 30 degrees. Then assess the tympanic membrane on both sides using an otoscope and make sure it is intact. We need two examiners for this test. The first examiner pulls open the eyelids so that nystagmus can be assessed. The other examiner pushes the cold water. We need a large syringe and a long flexible tubing as shown. Insert the tip of the tubing into the middle ear and start pushing cold water. At least 50 cc of cold water should be available in the syringe. The ice should be observed for nystagmus for at least 1 minute as the cold water is being pushed into the ear. If the brainstem is intact, there will be a slow component of the nystagmus towards the ear being tested. So the ice will move slowly towards the ear, followed by a rapid movement towards the center, or the fast component will be opposite to the direction of the ear being tested. Wait for 5 minutes before testing the other side. Check for pupillary reflex by shining bright light into the eyes. In a brain-dead patient, the pupils should be mid-sized, between 4 to 6 millimeters, and fixed, meaning they don't react to light. There should be neither direct light response nor consensual response. If the pupils are very small, let's say less than 2 millimeters, that is typically seen with opioid overdose and it is not consistent with brain death. Automated pupillometers are becoming increasingly popular in ICU for this exam, but they have not been systematically studied. Assess corneal reflex by using a cotton swab. It is important to test this at the right location. You should be touching near the junction of cornea and sclera. If you touch the sclera far away from the cornea, it is not a proper way to check for this reflex, so make sure to touch at the right location. Keep in mind that spinally mediated reflexes can be seen in patients who are brain dead. Several of them have been described. You can scan the barcode shown on the screen for a direct link to this section of the article from American Association of Neurology. I will also provide a link in the description. If you see a movement and you are not sure if it is a spinally mediated reflex or if it was a voluntary movement from the patient, then just make a note of it, complete the rest of the exam, and proceed to ancillary test. We will discuss more about this in step 4. The basis for apnea test is that respiratory acidosis is a potent stimulator of the drive to breathe. So when the blood levels of carbon dioxide rise or pH fall, it should really stimulate the brainstem to increase the respiratory effort. So when we stimulate the brainstem by raising the carbon dioxide level and dropping the pH of the blood to an appropriate level, and if the patient is still not breathing, that is a marker of complete loss of brainstem function. During apnea test, we basically discontinue the ventilator support. So it comes with a significant risk for hypoxemia and concomitant cardiovascular instability. Keep in mind that with apnea test, the main thing we are trying to achieve is hypercapnia and respiratory acidosis. We are not trying to affect the oxygen level. In fact, we are trying to prevent oxygen levels from dropping. So it is important to pre-oxygenate the patients with 100% FiO2 for at least 10 minutes for a target PaO2 of more than 200. It is also very important to maintain blood pressure of systolic more than 100 and MAP of more than 75 with fluid resuscitation and vasopressors as needed. Once these levels are maintained, then we need to obtain a baseline blood gas which should have a pH of 7.35 to 45 or normal and PCO2 between 35 to 45, again normal, or if you know the patient to have an elevated CO2 at baseline, the level should be around whatever is the patient's baseline. Once you made sure that these requirements are met, you can then proceed with apnea testing, which involves disconnecting the ventilator from the patient's endotracheal tube. You can provide low-flow oxygen through a catheter placed into the trachea, but don't use high flow rates because that can provide some carbon dioxide washout. Then you closely observe the patient for any breathing effort for at least 10 minutes. If at any point you see spontaneous breathing, patient's brainstem is functioning and patient is not brain dead. Around 8 minutes, you can obtain blood gas. You want to make sure that these requirements are met. pH has to be less than 7.3 and PaCO2 has to be more than 60 points and more than 20 points above the baseline. For example, if the patient's PaCO2 was 45 before the test, then you want to make sure that it's at least more than 60 and more than 20 points above, which would be more than 65 millimeters mercury before you say we have stimulated the brainstem enough. If these requirements are not met, as long as the patient's blood pressure and oxygen are stable, you can keep monitoring the patient and repeat the blood tests until these criteria are met. You have to be careful in patients who have chronic CO2 retention. For example, some patients with COPD, some patients with obesity hypoventilation syndrome, they tend to be chronic retainers. If you know their baseline, let's say their baseline PCO2 is 65, then you can use these cutoffs. As long as their repeat PCO2 is more than 85, you can complete the testing. But if you suspect chronic retention but you don't know their baseline, then you have to be extra careful. You can estimate a baseline and make sure the test shows PCO2 more than 20 points above that baseline. But in these situations, you should get an ancillary test, which is step 4 of the brain death testing. Apnea test can be stopped when there is spontaneous breathing, which establishes that brainstem is working and patient is not brain dead, or when the test is complete, meaning you have observed the patient for at least 10 minutes, there is no breathing effort, and the blood gas meets the specific requirements that we talked about in the last slide. You should also stop apnea test when there is a safety concern. Remember, severe hypoxemia and cardiac instability are two potential complications of apnea test. And if there is hypoxemia or any cardiovascular instability, you should immediately stop the test, reconnect the ventilator to the breathing tube, and briefly hyperventilate the patient to blow off the CO2 that has been building up. If patient's condition permits, you can obtain a blood gas just prior to reconnection, because if you have already observed the patient for more than 10 minutes at this point, and the blood gas just before reconnection shows results that meet the criteria for pH and PCO2, you have still technically completed the apnea testing. At this point, we may have enough information to make a diagnosis. If there was any response during neurologic exam, or if there was any respiratory effort seen during apnea test, these are consistent with life and patient is not brain dead. If the answer is no to both, then brain death can be confirmed without any further testing. However, if any aspect of the testing could not be completed, for example, if the patient has perforated eardrum and we cannot do oculovestibular reflex testing, then what we should do is do all other aspects of testing. So we should still check for corneal, pupillary reflexes, cough, gag reflexes, and so on, including the apnea test. And if there was any response seen, then patient is not brain dead. If there is no response to all of the other aspects of testing, then we should proceed with ancillary testing before confirming brain death. Let's look at some important indications for ancillary testing. Inability to correct metabolic abnormalities that were discussed under prerequisites. Inability to perform any part of the test, including apnea test. There is only one exception to this rule. If you are unable to perform oculocephalic reflex, for example, let's say patient has cervical collar and you're unable to tilt the head sideways, then you can skip this one step. provided you can do the oculovestibular testing bilaterally. Inability to clearly interpret any part of the exam. For example, you're doing pupillary reflex testing and you're not sure if the pupil moved. You thought maybe the pupil constricted a little bit, but it was not very clear. Or during the apnea test, you felt maybe there was some respiratory effort, maybe the chest moved, but you were not sure if that it was a breath. Then you should perform ancillary testing. Chronic CO2 retainers in whom the baseline is unknown. This was specifically included in the 2023 update by the American Association of Neurology article. Now keep in mind that ancillary testing is not superior to and does not substitute clinical exam. You still have to complete all the other parts of the testing except for the test or the step that you cannot perform before proceeding to ancillary testing. Ancillary testing is based on this rule. Any evidence of cerebral blood flow precludes brain death diagnosis. So we have to show complete cessation of cerebral circulation using one of these modalities of imaging. Digital subtraction angiography is considered more accurate but is labor intensive and there is risk for nephrotoxicity. Radionuclide scintigraphy is a perfectly acceptable alternative and is most commonly used. Transcranial Dopplers can be used, but keep in mind it can be only used in adults and in those without any skull defects. In the past, a flat line on electroencephalogram or EEG was considered an acceptable ancillary test, but there can be false positives and false negatives. So EEG is no longer accepted as an ancillary test. That was an important update in 2023 as well. And also don't use other forms of imaging like MRI, MRA, or CT angiogram. SSEP stands for somatosensory evoked potentials. It's another form of EEG testing that's also not acceptable. Brain death is a high-stakes decision. It is important to know the local rules. Certain states may have additional requirements, like they may want 2 physicians to independently do the testing. Certain states may want physicians with training in neurology or neurosurgery only to do the testing. It is also important to very clearly communicate with family. It can be very difficult for family members to understand that their loved one may be dead despite having a heart rate and blood pressure. So it's important to explain the process and inform in no uncertain terms that brain death means death for medical and legal purposes. For standard documentation, time of death is the time when arterial blood gas value was reported. Or in cases where ancillary testing was pursued, time of death is the time when the ancillary test was officially signed. Once a patient is declared brain dead, there is no obligation to provide medical care because, again, brain death is death for all practical purposes. Now let's look at some special situations. If the primary site of injury is infratentorial, for example, massive cerebellar hemorrhage, that's a unique situation because normally in other situations like large cerebral ischemia or subarachnoid hemorrhage, the brain injury or the actual death of the brain tissue progresses rostrally to caudally, such that when brainstem function is completely lost, it indicates complete evolution of death of the brain. That is not necessarily true if the primary site of injury is infratentorial. So what do you do in this situation? You should obtain brain imaging and prove supratentorial injury as well. For example, there should be hydrocephalus and herniation of the brain tissue. Then only you can proceed with formal brain death testing. Another special situation is a patient who is on ECMO. Here, an external circuit is not only maintaining the oxygenation and removing carbon dioxide from the blood, but it is also responsible for pumping the blood into the circulation. So if a patient is on ECMO, it is not a contraindication to do brain death testing, but you have to take some special precautions. I won't be going into the details of that, but you can find that information through the link in the description or by scanning this barcode. Pregnancy is not a contraindication for brain death testing, but the question is, what do we do with the baby? If the baby is mature, the baby can be delivered. But if the baby is not mature, then it's a complex situation. All pertinent experts like obstetrician, pediatrician, hospital ethics committee should be involved in decision making. It is generally recommended to continue incubation in the mother's body, allowing baby to mature. Let's look at some key points and wrap this up. Brain death is complete and permanent loss of entire brain function, including the brainstem. This is a legal method of determining the death of an individual. There are 4 steps involved in determination of brain death: prerequisites, neurologic exam, apnea testing, and only if needed, ancillary testing. This sequence must not be changed. Individual states may have some additional requirements that must be followed. There are also some special situations where some additional steps must be taken before confirming the brain death.